I'd like to introduce the panelists. You've gotten to know Bob Berenson pretty well, if you didn't know him before today from this conference. Gail Walensky is a senior fellow at Project Hope, and she was the former administrator of the Healthcare Financing Administration during the time when the fee schedule was implemented. And we have Jonathan Blum, who's Executive Vice President, Medical Affairs at Care First Blue Cross Blue Shield, which is the plan that covers this area. And he's the former Principal Deputy Administrator at CMS and also a veteran of the Senate Finance Committee staff. Karen Fisher is the Chief Public Policy Officer at the Association of Medical Colleges, and she's used to be Senior Health Counsel at the Senate Finance Committee. And finally, Eric Schneider, who those who've been with us all day met early this morning, the Senior Vice President for Policy and Research at the Commonwealth Funds. And we're going to run this panel in this order of people. Bob Berenson and Gail Walensky have very well-known positions on this perspective of, to what degree of resources, investment, capital, political capital to put into revamping the fee schedule versus alternative approaches. So they're going to present their thinking on it, and then the other three panelists will give their own thoughts, which I haven't debriefed them on yet.
So it's nice to be back up here again. Victor stepped out of the room. He accused me earlier of setting up a false dichotomy between fixing the fee schedule and proceeding with alternative payment models. As you're going to see, that's not my position. That actually is HHS's position. As you remember, if from a couple of years ago, the secretary presented a chart in which there were 4 categories of payments, and basically category 1 was fee-for-service, which was labeled as no relationship to value. There's Victor. I was just talking about, I actually don't think there's a dichotomy between working on fee schedules and working on alternative payment models, and I'm going to explain why in my presentation. I was being maybe well, in any case. So HHS had that categorization. Category 1 is fee-for-service, which has no relationship to value. Category 2, you add some quality measures, and you're now on the value trajectory. And then 3 and 4 winds up with population-based payment with risk-bearing. So if you could open up my slides for me, there it is. My argument, in fact, is that fee schedules can provide more or less value themselves. It is not right that value comes only from performance measurement and financial risk-bearing. There is no question that there are some inherent incentives with fee schedule-based payment. If you want to really get the indictment, you would see a quote by George Bernard Shaw in The Doctor's Dilemma from over a century ago, which said that because bakers can, because we've learned that you can pay bakers to make bread for you, we should give a surgeon money for taking off your leg and nothing for keeping it on. In his case, he said, it makes me despair for political economy or something like that. But it is fundamentally a problem with fee schedules. You're rewarded for doing stuff, some of which is unnecessary, and not rewarded for not doing stuff. As Joe was talking and the previous panel was talking, you do have an issue of trying to pay for the marginal costs rather than the average cost. And so I'm not necessarily saying that fee schedules are perfect or the right way ultimately to pay, but my point here is that you can get a lot more value out of fee schedules than we have been achieving. And I have two sub-bullets to make the point. I think it probably is a good thing that CMS is now identifying particular care coordination type activities that can be codified. And I actually wrote a piece about 15 years ago on the whole range of activities we want physicians to be doing, lots more communication with patients, with other doctors, et cetera, that involves lots of phone calls, lots of emails, lots of stuff that you can't pay on a fee-for-service fee schedule basis. The transaction costs are greater than the value of the service. You've got moral hazard problems. By that I mean patients sitting at home drinking coffee, doctors sitting in their office drinking coffee, and every time they send an email back and forth, somebody's going to be paying for it. That doesn't make a lot of sense to me. And you've got potential for abuse, program integrity issues. So I don't think everything can be accomplished with a fee schedule. And in fact, consistent with Joe's recommendation, one of the payment models that I find most attractive that CMS is proposing, or CMMI is testing, is called CPC Plus, Comprehensive Primary Care Plus. And Track 2 actually reduces the fee schedule, the amounts of fees in the fee schedule, introduces, they don't use the term capitation, I think it's a care management fee or something like that, but it's a PMPM. And it is the kind of hybrid model that tries, I think, to balance incentives. So, but having said that, there are things you can do with coding if you can have a code that can be crisply defined, that it's got significant value, that you can control the potential for abuse, gaming. I think that's a good idea, and CMS has been over the last few years, and I think John may have been responsible for getting all of this started when you were at CMS. You can clarify that for us. I think that's great that they've been doing that. And then the second thing is more basic. How physicians spend their time and what services they provide or order affects value as surely as measuring and rewarding or penalizing a handful of quality measures. If physicians are paid a lot for recommending procedures and then performing procedures and very little for spending time with patients, they will, I'm not giving you anything new, this has been talked about on a number of the panels, so the relative fees matter. And I don't think in that area CMS has had it right. I think that we are continually overpaying for mostly minor procedures. For major procedures, we have this problem of too many visits are being put into the global fee. For minor procedures, the time it takes is far less than the assumption that's in the fee schedule. And I think the biggest area, which our empirical research confirmed, was that test interpretations, to somewhat imaging, but other kinds of tests like echocardiograms, electrocardiograms, other kinds of test interpretations, I think are the category that is most overvalued. So we get lots of those services and spend a lot of money on those. And so I think we can get more value out of a fee schedule. But there's another set of reasons why I think we need to be paying a lot of attention to the fee schedule while we are also trying to support alternative payment models. On the PTAC, and Grace was mentioning earlier her experience, for those who don't know, the PTAC is the physician, see if I can get this right, Physician Payment Focused Payment Advisory, Technical Advisory Committee, right? Something like that. Physician Focused Payment Technical Advisory Committee. There's 11 of us. This was set up under MACRA. There's 11 of us, and neither Grace or I are speaking on behalf of PTAC, but we have impressions having served on PTAC now for almost 2 years. And as she mentioned, there are some very good innovative approaches to delivery changes that physicians, many of whom are specialists, are proposing. But when, I don't want to overgeneralize, a few of them, clearly the solution is let's create a code. It's not a payment model. It is a code. You want a code for something. There are issues in creating codes, but I'm just saying that not everything needs to be solved with a payment model. APMs are not easy. We're now in about the eighth year of, seventh, eighth year of CMMI actively pursuing demonstrations. We do not have any consensus, as far as I can tell, as to what direction we should be going with alternative payment models. We have strong advocates for episodes. We have other advocates for ACOs with shared savings, ultimately going to significant risk bearing. But I don't think we're close. So fee-for-service is going to be here by default for a lot of the healthcare system. And in the discussions from this morning, I guess I would say a lot of what are being proposed are aspirationally correct, but we have, as Alan, I think, correctly pointed out, a crisis in primary care right now. The Institute of Medicine issued a report a few years ago on the workforce for an aging population. We have no geriatricians for an aging population, virtually none who are actually practicing. They're mostly supervising to the extent that there are any. And I think a fee schedule could be constructed to reward more generously the services that certain specialties perform, and that should be a legitimate basis for modifying the fee schedule. Now, right now, as I emphasized this morning, that has to be done through statute. That's an unwieldy process. I would suggest perhaps there should be some amount of the fee schedule spending that could be within the discretion of the secretary to allocate into services that would achieve particular policy objectives, and that can be done while we are trying to get APMs right. Current payment rates are used as integral parts of most APMs, so that if you have misvalued RVUs and fees, these would be extended to APMs. Some of the innovative proposals want to share savings, for example, by billings. Well, if billings overvalue the work of certain specialists compared to other specialists, you will maintain the disparities in rewards, et cetera. So to price APMs, we're typically using fee schedule prices, DRG prices, to come up with a composite rate for a bundle or an episode, et cetera. To just reiterate this point, I think where we want to wind up is probably hybrid payment models that attempt to neutralize financial incentives, not create strong financial incentives, balancing the incentives for stinting with the incentives for overproducing, and that's what's the second part of CPC Plus, the second track of CPC Plus explicitly, I think, is set up to try to do. And then Bruce mentioned earlier that he thought I was the one who said you have to fix the fee schedule in order to do away with it. This was the bullet that's relevant to that. I think I did say that. It is that a lot of reform, I think, needs to be based around the development of multi-specialty group practices, willing to work in a team-based, multidisciplinary environment, taking a population-based risk taking risk for a population of patients. When you have disparities of 2 to 3 to even more to 1, specialty income to family physician, general internal medicine, pediatrician income, in the fee schedule, it is that much more difficult to establish a well-functioning multi-specialty group. I think, Alan, were you the one who said you're having trouble recruiting primary care physicians in your group? And if you have a cardiologist who can make $600,000 in fee-for-service, how are you going to get them to work for $400,000 or $350,000 in a multi-specialty group? So my argument is by correcting some of the distortions in fee-for-service, not having everybody paid the same, but by reducing the disparities somewhat, I think it supports the development of organizations that ultimately will be in a position to either manage episode-based payment or where I would prefer move towards capitated type payment. So that's my sort of argument for why we need to consider the fee schedule part of the value-based payment movement. We should not have this assumption that fee-for-service fee schedules are just valueless, and just by adding some quality measures and taking some non-nominal risk, we suddenly have value. And with that, I'm going to turn it over to Gail.
As is frequently the case, what is positioned as opposing views turns out to be somewhat more nuanced than that, and that's going to be the case here. In principle, having more accurate is better than having less accurate, so it's kind of hard to say at a conceptual level it would be undesirable to have a more accurate fee schedule. And it would certainly be helpful to go after the significantly, and you can decide how to define that, either overvalued or undervalued services. The problem that I have is at what cost, how much bandwidth exists in the agency, in CMS or MedPAC or your physician advisory group. And even more to me is, as a standalone, the concept not so much of the fee schedule or fee for service, but the micro unit fee schedule that we have focused on is inherently against the focus on outcomes. The persistent focus on inputs and the costs of a particular input as opposed to what you get for that puts you in an undesirable position in terms of trying to acknowledge that there frequently are, can, should be different ways of getting to a health outcome that you're trying to have. The extreme case being getting paid for cutting off someone's leg as opposed to preventing the need for amputation. But it's a reminder that focusing on the inputs can lead you to places you just as soon not be. And for me, even an improved fee schedule, as long as it maintains its very micro level focus, is not going to help us move forward in terms of trying to improve quality and outcomes. I am struck by what seems to be increased agreement from some very unlikely quarters with regard to what you'd expect for agreement, on how urgently we need to reduce the number of outcome metrics and quality metrics that we are using to get greater consistency by using a smaller set of outcome metrics that actually matter and trying to get them in broader use by different payers. And that is what troubles me about wanting to use up too much either bandwidth or capital, political capital in particular, on improving the fee schedule. So to the extent we can figure out how to go after the most egregious over and undervalued services, especially given that the fee schedule is the basis, at least now, hopefully not forever, but now, for many of the alternative payment models, that would improve it. But you are going to end up still at a micro unit focus, and that makes it very difficult to promote the notion of accountability, of responsibility by the team providing health care for the patient. To the extent we can promote more of a movement toward bundling and episode, you have an opportunity to cross different clinicians and to look at the outcomes in a way that becomes very difficult when you have the micro-level fee schedule. And of course, the fee schedule was constructed on the presumption that the payment should be the same regardless of who provides the service. I mean, that was the underlying philosophy for the relative value scale. And there's almost, an irony, I guess is the best word, now we're trying to figure out ways to get around that fundamental concept because we don't like the income distributions that are being produced. But it's hard to imagine a more challenging way to go change income distributions than to have a micro-unit focused fee schedule where the presumption is whoever provides that service ought to be paid the same for providing the service, because it doesn't matter the quality and outcome, it matters something about the input costs that are provided, is going to be able to effectuate the kind of redistribution of income that I've heard this already, Bob, but the last panel also talk about. It is just contrary to the basic nature of what that goes. So I guess I would summarize my position of saying if it doesn't cost too much, it doesn't deflect too much from where I think the focus really needs to be, which is on trying to move more to an outcomes focus and to an agreed upon set of quality and efficiency metrics. You are not exhausting all of your political capital, which you may have noticed is actually in quite scarce supply right now. Then it's hard to say, no, it would be bad to have a more accurate fee schedule. But I am worried about the bandwidth problem. It seems like we are struggling enough as it is with regard to trying to move to a more outcomes-focused activity. And as I frequently do, I'll end by saying it always takes me back to Joe Newhouse's partial capitation world, where you acknowledge an interest and importance of having both a base payment and having a variable payment, and you can decide how much it ought to be. I tend to be less on the variable and larger on the fixed, but that strikes me as being inherently a better place to be moving than to focus on a very micro level fee schedule. So I tried to distinguish more recently in speaking. It's not the fee for service per se, it's the service at the micro unit level, which I think tends to get us in the most problem, because you could argue that episodes, et cetera, are also fee for service, just a much bigger service unit that's involved.
Okay, now we'll hear from Jonathan Blum.
So I'm going to kind of offer some thoughts, not from my former life at CMS, but my current life at Care First Blue Cross, and seeing the world differently, similar issues and similar concepts and similar goals that I have today that I did back at CMS, but a different access to information, different access to data, and a different perspective. And I think given where I sit today, probably more skeptical than I was previously that we will see a world of new payment models other than fee-for-service. And for a couple of reasons. First reason is when we look at our data within Care First, we don't see our members staying within one hospital system. And I think when the policy community, at least during my time at CMS, thought about how to think about how Medicare beneficiaries receive their care, they tend to think about ACOs and accountable care organizations being the home for all of the care that a given beneficiary sees. What we see in our data is that members travel to different systems, different care delivery systems based upon their different conditions. And think of the person that has multiple chronic conditions. They're not going to one place for all of their care. They're going to maybe MedStar system for fantastic cardiac care. They're going to Johns Hopkins for fantastic other care. They have a primary care physician who's independent, that's really trying to be the quarterback to their complex needs. We in the private payer world aren't very comfortable to tell people where to go for their care. And the Medicare program, it's not very comfortable telling people where to go to receive their care. The foundation is that people get to choose where they want to go. So that being said, thinking about payment models that lock in people to given delivery systems for all their care, all their condition, that's not how people choose to receive their care. And so for that reason, I'm very skeptical that we'll ever see clinical bundles or other models that really capitate the care to one given system, one given ACO, or one given hospital system. The second insight that I had coming into Care First that I didn't necessarily have during my time at CMS is that the differences that we see in care delivered for a given episode of care, in the CMS context, you see data, you see wide variation in costs and care, same geographic area, and you come to the conclusion, well, that doesn't make sense, that it's not rational. And I think in the private sector, at least from my vantage point right now, you can really see the individual care journeys that somebody takes. And the reason why they chose SNF care versus home care isn't because the system was producing a irrational result, was that the person didn't have somebody at home to let the home health agency come in the door. Therefore, the physician team felt that SNF care was the best, not for the best clinical outcome, but for the best social outcome. And so when you really dig into the patterns of differences in care for a given episode, hip surgery, knee surgery, a given procedure, you can look at population level data and begin to see patterns that just don't make conceptual sense. And therefore you conclude, well, let's go to bundles to really change that incentive, to change that variation. But when you really dig into why the physician thought that SNF care or this hospital versus that hospital or this physician versus that physician was the best for the patient, there are social circumstances that our risk adjustment processes don't control very well for. So given just those two reasons, people don't choose one hospital system, one ACO for all their care. When you really dig into the differences in care and pattern, it leads you to conclude that whatever payment system that we get to in the future, be it full capitation through competing private plans, through APMs, they're going to be based upon the fee-for-service chassis. And every model that comes to us that's proposed by a given physician organization really is a shared savings concept, back-end savings after you calculate the savings. So I don't personally believe we're ever going to get to a world of capitated alternative payment models. We'll get into risk sharing, and that's important, and that's a worthy goal. But we're still always going to rely on the fee-for-service payment systems as a chassis, as the infrastructure, and the fail-safe of payment to systems when people don't necessarily follow care patterns that are rational, but make perfect clinical sense when you really dig into the circumstance and the care decisions, and the fact that people don't lock themselves into one given system. My family chooses to receive care from 3 different systems here in this area. They're all wonderful systems, but we would never agree to have all of our care provided by one system, nor could one system provide all of the care that my family needs. And the policy community, when it talks about bundles and clinical bundles and procedural bundles, I think doesn't always take into account some of the very human things that happen and the very real clinical decisions that happen that aren't always apparent when you look at national data. And for that reason, I am more confident than I was during my time at CMS that the fee-for-service structures will stay in place. We'll rely on them, and we have to find the resources. We have to find the staff, the money, the contract dollars to make sure that we're paying accurately, because I will predict in 10 years from now that the fee-for-service system will still be in place 20 years from now, 30 years from now, unless we start being comfortable locking people into one system in care, and unless we start taking away the real clinical human judgment that goes into deciding when a patient needs SNF care versus home care versus rehab care, when it's not just the clinical need, but it's the clinical and the social circumstance that drive those decisions. So with that, I'll turn to my colleague, Karen.
Thank you, Jeff.
Okay, great. Well, I think John was pretty explicit about your views on the fee schedule and where that's going. You know, we could probably spend the whole panel listening to John because of his experience where he is currently, and plus his rich experience when he was head of CMS, where you really did take on the fee schedule and looked at misvalued codes and the RUC and what was the valuation of that issue. To the point about that sometimes you have to look beyond the numbers and see what individuals' decisions are and that there are things beyond just looking at the financial incentives. I think we're seeing that more recently even with socioeconomic status and those indicators and how that affects the care that's given to people and individuals. And I think we're going to see that start to play a role with involved with many of these things. I'm just going to do a sort of a smattering based on what I've heard before. I would say if we look at the current fee schedule, you know, it's been mentioned before about whether you do a primary care add-on to sort of help buttress up the primary care payments. The complex code and the care coordination codes, I think, have been valuable, and I think after a couple of years of, you know, sort of stymied growth till people were learning what you had to do to get those codes, it seems like they are making progress. The palliative care codes that are being offered. So there are tweaks that can be added in that front. But, you know, it is beyond even the physician fee schedule. And I just came this morning from a discussion about workforce, and there was a lot of talk about, you know, other types of providers beyond physicians. And when we look at it and we say, I don't know who decided it, but it was 85% of the physician fee schedule that we would pay nurse practitioners and physician's assistants. And what role do they play in the healthcare system, and what is the valuation of the services they play, and do you base that off of the physician service? I would also say that when Gail talks about what is the bandwidth, and if you tackle the fee schedule writ large, I do agree that you really have to make a decision about, do we think the fee schedule will be that chassis for APMs going forward in the future? Because when I was on the Hill and physician payment was in my portfolio, I was always a little bit disappointed because so many meetings with specialty societies were about individual codes and what the valuation was for an individual code. And I thought, boy, it would be great. There's really smart people here in this room if we could have a broader discussion based on your on-the-ground experience about the healthcare delivery system and how you think it can be changed. But that code was so critical to them and what the payment was for that code. And if you start to go in and looking at that, I think what it would evolve up into, again, would be this food fight about looking at individual codes on that front. And on that, we've seen that a little bit with the misvalued code initiative that I think was in PAM, I think John started and then Congress passed, that said, look, if we can't figure out misvalued codes that people generally agree are overvalued, there's going to be a reduction taken out of the entire fee schedule. And my understanding, I think now, is that they're still not finding enough of those. And I think, I will tell you, I think the underlying thinking of that was that the physician community knew which codes were overvalued. And if you put it to say, if you either tell us or everybody's going to take a hit, that people would come out and say, I'll tell you, those guys were overvalued, go look at them. And it really didn't happen, I don't think. And maybe that's because the reduction wasn't enough. Someone said, I'll take a 0.5% reduction across the board because I don't want someone pointing the finger now to my codes in that arena. I also would say, as we look at APMs and alternative payment models, I do think when we look at the fee schedules writ large, we do need to look at them in the context of the direction, at least right now, where payers and the policy community and the federal government want providers to go, and that is to alternative payment models. So that we seem to be encouraging people to go to alternative payment models, but at the same time looking at individual payment systems. And so when we see growth there, and I think this might have been alluded to in the previous panel, when we see growth somewhere, we say, oh, that's a problem. But maybe that's not a problem if you look at it in the context of an overall alternative payment model, so that if you see some type of specialty or something growing, and maybe it's because it's now being able to be done in the outpatient and in the clinic setting, and you're avoiding an inpatient, hospitalization, that's a good thing. If the concept is those physicians are part of an ACO or whatever, and they are looking at the overall payments and overall cost and not looking at that individual silo. And I feel a little bit as I watch, I think policymakers, and we're all sort of stuck into, we want to move people to APMs, but we still keep going back to looking at a sector-specific analysis of everything. And I think as we move on, we just need to think about that type of arena. And then finally, John talked about bundles versus ACOs. I always thought, after spending a number of years in this space, that CMS's expertise, maybe at MedPACs, was moving more into the bundled space. You have individual units. The DRG system had evolved into bundles. You have now the outpatient system moving into consolidated APCs. And it just seemed like it was a natural transition that you'd move more into the bundled space, which would allow people to go to whatever healthcare system. And then we sort of had ACOs sort of in the checkerboard, sort of jump the track a little bit and jump ahead of this. And a lot of time has been spent on that. And I think we're still not clear, and now we sort of have this mixture of bundles and ACOs. It's still unclear which direction it's going in, but I do think at some point someone needs to make a decision about that. In terms of resources by CMS, is bundles the way to go, or looking at systems and ACOs the way to go in the future? And I think that has yet to really shake out in that front. And then I'll finally say, as someone who worked a little bit on MACRA, the one thing that really surprised me coming out of MACRA was the immense interest in physicians wanting to do APMs. I sort of thought people would stay in this MIPS, I'm assuming everybody is familiar and knows the acronyms, and doing the MIPS and see if they could get on the higher end of the median and make some money that way, particularly because the legislation threw in a bunch of money for the top quartile of people. And yet immediately the discussion went to APMs. And I don't know if that was because when people did the math, the 5% bonus looked very valuable to them on that front. But just as an observation, I thought it was interesting how that discussion moved there, rather than saying we're going to work within the fee schedule. So with that, I'll stop.
Great. Well, for those of you who are movie buffs, there's a character that sometimes shows up at the beginning of a movie, and then when he shows up again, you know it's getting close to the end of the movie. And since I was first early this morning, we're now at that part of the end, almost to the end of the movie. So I'm going to be a little provocative. First, I want to start by saying to Paul and Bob, thank you for organizing this wonderful day. It's been tremendous discussion. I've learned a lot. I'm sure others have learned a lot from this discussion and for a lot of perspectives expressed. And so on behalf of the Commonwealth Fund, we're grateful for what you've organized here. I believe that the physician fee schedule will be with us for a while, as Bob does. But I also believe that Gail is onto something around the potential distraction that it represents from other objectives that we have in the healthcare delivery system. And one question that occurs to me, having listened to the day, is whether the physician fee schedule prevents innovation by locking in outmoded models of clinical practice. So one of the things we're seeing in other industries, and this was alluded to in the previous panel, is tremendous innovation on the production processes for delivering goods and services. That has been happening at an accelerating pace over the last 20 to 30 years. And we also are on the precipice of a really powerful digital revolution that we're only beginning to grapple with, not just in the healthcare sector, but actually outside of the healthcare sector as well. There are potential ways of delivering services that we can't even imagine today that might be very real to us 5 years from now. I don't think anyone thought, to allude to my earlier metaphor, that we'd be carrying around high-powered computers in our pockets and our purses 10 years ago. I certainly didn't think we were going to be doing email in 1992 when I first got into this area. I don't think we should underestimate the potential for innovation to really change the way the healthcare delivery system does its business. The physician fee schedule could be a powerful barrier to progress in that area, and so we should be looking hard at the ways in which it might be preventing that type of innovation. So what I wanted to think about, or what I ended up thinking about, were, I'll say, four needs or wants that might guide activity in evolving the physician fee schedule, and also APMs, because I think it would be nice to align these two objectives, competing objectives, one about how to figure out how to value the work of the system, and the other about how to value the health outcomes and other patient and public goods that it's supposed to produce. So the first is around delivery system innovation. And it's really interesting to think about focusing on the high-need, high-cost population, which is a big focus of the Commonwealth Fund right now and 4 other foundations that have joined us in focusing on that group, and thinking about whether the delivery models and the innovative delivery models that serve high-need, high-cost populations, how the fee schedule plays into the care for those populations. One of the things I like to say is that we're in the business of trying to take high-need, high-cost patients and turn them into high-need, low-cost patients. And if the fee schedule prevents us from making that sort of a transition, then we should highlight the areas in which that's happening and think about what that means for coding and valuation of services in that context. The second sort of need or want, I guess, is what I would call a set of goals, thinking about what our goals are for the APMs and or the physician fee schedule. So it by its very nature, the fee schedule is a policy statement. It sort of drives what's likely to happen, and we've heard that detailed very nicely today. But one possible way of reorienting this is around not the work, not using the work and the description of the work as a way of defining the fee schedule, but thinking about the patient-oriented models that the APMs open up, which I think might be one of the reasons they're attractive to clinicians, because many clinicians actually want to serve the needs of their patients more effectively. So patient-oriented APMs could be very powerful, and aligning those incentives between patients and providers in thinking about how to produce savings, how to produce better outcomes could be powerful. We've talked about service goals as another important outcome. So better care coordination. We might actually juice the fee schedule, create codes. In fact, that's happening for better care coordination. But one can think about other goals, such as better education of patients, helping them achieve adherence, better communication, not just with the patient, but also among team members. I've been struck by the cognitive input discussion, or the discussion of the value of cognitive services. And in my experience, there are good cognitive services and badly done cognitive services. I think if we could get smarter about how to measure when cognitive work is being done well, we could make interesting progress on revaluing cognitive services. And what I mean by that is that we're now on the verge of being able to do decision support, digital decision support, use computing power to assess whether decisions that were made were actually for appropriate care, appropriate diagnosis, imaging, treatment. And we don't have to necessarily rely on rigid protocols to achieve that end. We could actually do real-time research using a sort of digital capability to understand how decisions are being made in systems and whether they're producing the services and the outcomes that we're interested in. So this sounds a little futuristic, I know, but again, I really do think we're on the precipice of something big in the digital revolution space, and we're seeing it in other sectors of the economy. The third need or want that occurred to me was, and it's funny, I haven't heard this at all today, which is the idea of patient or public input into the valuations of the PFS. It's as if we've decided that's not even a possibility. There are some methods for gathering that sort of input from the public and from patients, It's not easy to do, but they could certainly define services. There you can figure out mechanisms for getting public input into the definition of value, the definition of what people are willing to spend on various types of services. Oregon did this a couple decades ago now under John Kitsaber. And I think there could be some more experimentation there on getting the public input to the nature of the physician fee schedule. And then finally, I think it would be useful to try to plan a deliberate transition toward some future type of physician fee schedule or improved resource coding and valuation. Much the way if any of you have been across the Tappan Zee Bridge over the Hudson River, there's actually, the old bridge is still there, but there's a new bridge that they're building in parallel, and then once that one actually can hold traffic, they'll just demolish the old one. And we tend to sort of think, well, we're just going to jump, but maybe we need to think about sort of how we would leverage a sort of parallel world where we're actually implementing APMs and could use the APMs to learn about how we would structure a new type of physician fee schedule. And the two pieces I see as sort of potentially important infrastructure developments, and every week is infrastructure week now, by the way. One is better developing the data systems to support this new vision of a physician fee schedule. So those are resource management systems that actually could align with what ACOs and other organizations are trying to do, so that there would actually be a sort of standard around the resource management systems that could be widely used. And then the quality measurement investment. We've gone through version 1.0 of quality measurement. Everyone's kind of disappointed with that. I think we could use another round of investment in really novel and creative ways of measuring quality, patient-reported outcome measures and patient-reported experience measures, and how to incorporate those into the PFS. And then last, I did wonder whether CMMI could use some of its authority to develop and test alternative coding and valuation systems in some local markets in parallel to what exists right now. I know, again, this is probably sounding futuristic, but it's the end of a long day. And so I'm trying to let my imagination loose and get outside of the box. So thank you for your attention.
Before I go to the panelists for their other thoughts about what their colleagues have said, Eric, I wanted to ask you a specific follow-up question. It was a very interesting comment you made about innovation in medical care and whether a fee schedule is a hindrance to innovation. And I was thinking it would be the opposite. I would think that bundled payment would be the biggest threat to innovation as far as its tendency to freeze in a particular approach to a particular type of patient, whereas fee-for-service, has the complete free, all the tools are there, and using them in different ways would be more seamless. I don't know if you have any thoughts.
Yeah, I think one has to be very careful in the designing of bundles. I don't know whether fee-for-service actually does what you're describing. I think of the Medicare Advantage companies that are emerging to manage high-need and high-cost patients at home. So we've talked a lot about service setting today and practice overhead costs. Well, what are those costs in the home? So there are, I think fee-for-service doesn't really allow them, to me, doesn't allow the maximum amount of experimentation. Bundles, I agree, would actually be more problematic if they lock in particular ways of using resources.
Turn to panelists.
I was surprised by, thank you, I was surprised by John Blum's comment that he thought the current fee-for-service would be better at taking account of the social circumstances of the patient than one which paid on a broader basis, like a Medicare Advantage. It would seem the focus on an individual payment for units of service provided is exactly contrary. Now, it may be that I'm basing on what I observe. I've been a trustee for the United Mine Workers Health and Retirement Fund since 1993, and they are responsible for all of the health care to retirees and their dependents, and because they really are responsible for every conceivable medical event that may happen, they have been the most innovative in looking at if somebody is falling repeatedly and ending up with a fracture, sending someone in the home to see whether the steps can be built up or there's a handrail that could be aided. And when people were showing up with the ambulances because they were in remote places and didn't have transportation, they had more incentive to try to find alternative ways to get them delivered to their physicians without using them. The type of fee-for-service that we have now, especially in Medicare, which is a very siloed mentality of the physician per se and of little units of what the physician does, seems to me as antithetical as anything I could think of in terms of looking at the clinical and social circumstances of the patient. Even if the physician would like to, everything about the payment system works against that. So that struck me as a very odd statement.
I think just to clarify, I don't disagree that a payer environment can provide more flexibility in benefit offerings, benefit designs. I think just about every payer has an interest in providing that support at home or any other kind of care management that's going to avoid the care that's unnecessary. The point I was trying to make is that whether you're in a fully capitated Medicare private plan, you're in an ACO, that's on a shared savings basis, the challenge there is you have to figure out how one healthcare system talks to the other, that patients don't get their care, even within a capitation system, even within the best-run capitated health plan, people are seeing multiple systems. And if you want to design payment that's tied to an episode of care, a procedure, tied to a clinical episode of care, within that capitation, you still have to figure out how to pay providers that don't have a business relationship to each other. Therefore, you're going to have to focus on how to pay accurately, how to pay precisely for the individual service. And the notion that teams come together, I fully support that, and that's great, but that's not the reality of care that I see today, nor that I think the Medicare program experiences. And even the best sort of ACOs that we think about, a lot of their care is going outside of their service area. How do you think about paying providers that don't have the economic relationship back to that home base? Therefore, the fee-for-service system will be that chassis, and those payments need to be accurate. And that's why I think we need to both develop the best delivery models, but that's independent of thinking about how to make sure that our fee schedules are accurate, they send the right price signals, and they provide the means for one healthcare system to communicate to the other to ensure the beneficiary or the patient is getting the best possible care. And that's the point that I'm trying to make.
I just wanted to make a comment about picking up on something Eric mentioned about getting consumers, patients, sense of value in fees, and to make the sort of unfortunate point is that by statute, CMS has no authority to do that. You're supposed to pay for resource costs, so there's the relative value to patients or to taxpayers of the relative value scale is not something they can do right now. And the point, I'm not saying that you thought they could. There's no discussion at the congressional level, and maybe Karen could comment on this, about thinking of broader parameters for the fee schedule. It was put in legislation in 1989. It was adopted in 1992. We're still doing resource costs. We're sort of fumbling around trying to get those right. And some other obvious opportunities to introduce some notions of changing or modifying fees to achieve policy objectives, to modify fees to generate desired behavior of physicians, which is a little tricky, as the previous panel talked about, but is being done in some places, is just not part of the discussion. And to take it one step further, my understanding is that the staff at CM, the Center for Medicare, that is responsible for the fee schedule, is 9 people. The staff at CMMI for alternative payment models is a couple hundred. That's where the priorities are, and I guess I'm with John a little bit, is I'm not sure we're going to get there with that investment. In the meantime, we're not really doing anything to sort of re-examine what, we now spend $90 billion, basically, on the Medicare Physician Fee Schedule. The idea that 9 people would be at CMS to support that is sort of stupid. I guess is what I would say. It is not what any corporation would do to protect its investment of $90 billion. I mean, and then I'll stop this tirade. PPRC had a whole commission and 15 professionals who were worrying about every aspect of the fee schedule when it was operating, and now MedPAC has 1.5 or something like that, maybe 2. Who are great. It is, I think, sort of our commitment to the fee schedule has lagged. And so I'm not, so that's, I guess, one of the points I'm making is if we actually reframe the discussion so that people saw that improving the value of the fee schedule, which might include loosening up the statutory requirements a little bit, would contribute to value as much as our investment in developing performance measures or trying to get people to take risk.
And then, you know, as you say that, Bob, first of all, I don't think there was a lot of discussion. And when I was there was a group that did come up that wanted to talk about the fee schedule. But, you know, some of where the attention has gone, for right or wrong, has gone to cost measures for the alternative payment models and sort of holding physicians accountable for the total cost of care. So, you know, I don't know if it was PAMA or MACRA spent a large number of pages of legislative language talking about how you do attribution and episode groupers and who we're going to. So it's almost like as much time is being spent as we used to do on fee schedules and what's practice expense versus work or resource, we're now looking at trying to figure out how much to hold the physician accountable for the total cost of care, because for whatever reason we want to hold the physician accountable for the total cost of care. MIPS has that provision in, it's been delayed, but I think CMS is struggling with trying to figure out how to determine how much attribution be placed on a physician, and when they're a specialist, how much attribution should be placed on them for that total cost of care. And I'm not sure if that's the right place where they should be spending their time, but it's certainly out there that that's the direction a little bit of where they're spending it, and that is a very complicated area in and of its own.
One question to ask the panel. You know, I think throughout this day, a lot has come up about how little, not just political capital, but how few dollars we put into maintaining or improving the fee schedule. I guess it's not a surprise when a program has been in place for 25 years. It doesn't generate that. Which brings me to the question is that whether we just need, you know, some small amount of change or more radical change, depending on your opinion, how are we going to deal with this very under-resourced situation? You know, is there something that's going to capture the imagination of funders? I mean, people in Congress who fund this to give more resources? Or do we have to look very explicitly for steps to take that don't require much in the way of staffs and research contracts? I don't know if anyone has any thoughts.
I think there needs to be more of an agreement on where we want to go in terms of the organization delivery of healthcare before you can have any hope of getting that responded to. As somebody who has spent time in almost all those places, chairing PPRC and then MedPAC and the agency, the sense has been that, although not particularly correct, that the world is increasingly moving away from this micro-unit fee-for-service. There never was a lot of inclination to put a lot of resources into its support, and there is, if anything, less of an inclination now, because I think you correctly indicated, if you look at where people putting their money where their mouth is, and distributing the resources between the Center for Medicare and CMMI, it's clear where the views are in terms of the relative values of future investments, and it has not been in improving the accuracy of the fee schedule for whatever sets of reasons. And I think that there would have to be a significantly different discussion than what we've had as to where we want to go. I do worry that focusing on the physician fee schedule will stifle future innovation, because it focuses on input costs that have existed in the past. And to me, is by its nature, as opposed to focusing on what you want done, what you want to get at the end of traditional ways of doing something. But it's more, that's my opinion. What we, I think, really need to get is more of an agreement on where do we think we're going. If it is going to be fundamentally using the fee schedule as a basis for payment, then even though I think this will be it will be a brawl in terms of who prevails, changing the relative values for individual procedures, which has always been the case, or has been the case historically at least. That would be where we need to focus on, but it's hard to do it until we have some sense of here's where we think we're going to, or where we want to go to in our next round of payment.
I think it's certainly true during my time at CMS that the Innovation Center got more resource, was a huge attraction from the CMS staff that worked in more of the classic functions of the agency to move over to the Innovation Center. And what I used to tell people who are thinking about, deciding whether to stay in CM versus to take a new position within CMMI is there's so much power in the individual decisions that are made during the fee schedule annual process. And all the folks that visited Karen were all the folks that were ticked off at CMS because they had some code change or some political decision to change the overall priorities for how we thought about the time, different spending levels. And so I think we need to create, to Gail's point, the consensus where we want to go. There needs to be more investment, more infrastructure to how we think about the fee schedule. If we want to have a debate about whether to have the fee schedule based upon input cost, resource cost, or some other value notion, that's a great debate to have. And I think that to me is what's needed. And while we are developing new delivery models, payment models, but to, I think, build a consensus that, in my view, they're going to be built on the fee-for-service chassis, no matter how we design it, and then create the consensus, excitement within the agency too, for that development.
Any questions from the audience?
Me? Yeah. My question goes to the interesting
Could you
discussion.
identify yourself?
Oh,
first?
Carl Polzer, and
Carl.
I work on income inequality issues on one project, and I'm a paid policy consultant to the long-term care industry, just by disclosure. So I have a different kind of interest. On the issue of improving technology and productivity and how to develop an incentive for that in a payment system, we have some we have some precedent for that under the Affordable Care Act. There was a productivity adjustments made to nursing homes when I worked in the industry, and hospitals of about 1% a year, I think. So basically, the industry was being paid less to be more innovative and productive. And the research question is, and I have another question, do we know anything about how they absorbed that challenge? Like how much went to, how much in labor, how much in capital, and et cetera? I mean, how did they do that? That would give you some clue about a negative incentive. But what I hear here in terms of physicians, I hear we're going to make them more productive by giving them more. So anyhow, that's a question about how you incentivize more productivity.
Okay, let's see if there's a response. We'll hold your other question for later.
I guess maybe I'll take a first stab at it. I think the productivity reductions that were put into the statute, my understanding was a clear goal to achieve scorable savings from the Medicare program. I think in my own personal view, the pressure that was put by Congress and implemented by the agency on downward pressure on hospitals and other types of providers, created, I think, a different environment, created pressure to work together, created pressure to better coordinate care, created pressure to form ACOs. And so while it was a difficult change for the industry to absorb, at the same time, I think it sparked a lot of the conversation that we're having today about the best payment model, delivery model. So that downward pressure, I think, really created much more acceptance for value-based purchasing or other kinds of quality-based frameworks. But I think, Carl, your question is a good one. What happened? Did providers get more efficient, or did they take away services? I don't think we've ever looked back at what happened, but at the same time, I truly believe that that downward pressure that Congress put in place by the agency at the time did create the conversation that we're having today, is what is the future of payment, what is the future of delivery design, and without that downward pressure, I don't think we've been in a place that we are today.
But I'm astounded as though this is something new. There have been assumed productivity increases for decades in the payments, and it's like they'll figure it out. Since we're not very good at measuring actually what happens, I don't know we ever know because of the service nature of what is being provided, yet alone our data limitations. But I mean, for years, there's been a presumed productivity increase built into PPS updates and other updates without, I'm not sure how much that's ever studied, but it's not like this is in any way anything new. Hospitals certainly have had that for many, many years.
Yeah, I would just add one is Medicare margins for hospitals are negative. They're overall positive because they're getting money from other payers. So it gets a little bit tricky because of the nature of the hospital industry. And I think productivity, at least for hospital inpatient, for the most part, is reducing length of stay, because that's where a large amount of the costs are in the per day costs. And I think we have seen more movement into the outpatient settings. Part of that is technology, and the research has enabled things to move to the outpatient, but part of it is you can only reduce the length of stay for so much until things have to obviously move into the outpatient setting. And I think that gets a little bit harder on the physician side about how you sort of do those efficiencies that result in what most people view as better care. And maybe that is the reason why when physicians look at what productivity enhancements they can do, they look towards APMs versus what can they do within the actual physician fee schedule.
Just a follow-up. You might want to look at the nursing home.
Carl, we've been on this long enough.
Okay, sure.
Bob had a comment on what Gail
To
said.
make a comment on one of Gail's points, it is right with, in fact, I'm updating what's called BTOS for any of those who have ever heard of it. My obituary will lead with BTOS, the Berenson-Eggers type of service system. And in fact, right now I had to deal with 9,500 codes in the physician fee schedule, with those that are being dropped and those that are being added. And so, Gail, you are absolutely right that they tend to be micro units it's not inevitable. It's a technical matter. So you do have 90-day globals. The experience hasn't been terrific. If anything, the innovation has occurred. The care has moved outpatient, but we still assume X number of inpatient follow-up visits as part of that. So there, it has been that the payment hasn't caught up with the innovation. The other example is we have for decades been paying renal physicians a capitation for managing dialysis. And under Tom Scully's watch, somebody figured out that they weren't actually seeing the patients very often. And so the codes had to be modified to also throw in the number of visits performed in the month. So just as a technical matter, it's not inevitable. I don't know what the outcomes have been. I think they're seeing the patients more often, but in any case, I think there's probably a fundamental problem of thinking you can go to aggregated payments in a fee schedule, but I just wanted to clarify that as a technical matter, you could try.
Yeah, so hi. I've been involved with some of the CMMI models that are being developed on very different realms. And one of the things I keep asking is, what about co-payments? How are the co-payments going to work? How is that going to be folded in? And the answer is, we'll figure it out at the end. It seems to be, not to diminish anybody, but that feels like the thinking. And it started worrying me a little bit until someone said, no one pays the co-payments anyway. They all have secondary insurance, and there's like 5 guys somewhere who actually pay their own co-insurance. And it got me back to thinking about a colleague at PPRC who did a very impressive analysis in the early 90s about the cost to Medicare of supplemental insurance, because beneficiaries aren't in fact very price sensitive when they have a secondary insurance. So is that part of what we should be talking about? Like, besides how we pay doctors, is what skin in the game should beneficiaries have, and what difference can that possibly make in the presence of secondary insurance?
Well, somebody needs to have an incentive. And one of the problems is that when you pair fully insured for at least the services that are covered, as we all know, there are a lot of services seniors use that aren't covered at all under Medicare, but for those that are covered, they're usually pretty fully covered because of supplementary or secondary insurance. When you pair people like that with fee-for-service physicians, you have a bad potential dynamic coming together. If you pair individuals who don't have financial reasons to consider the volume of services that they're using with a group that is at some financial risk, especially if there's financial risk with some outcome. I was only half kidding of, well, did it make any difference that the renal physicians were seeing their dialysis patients less? Maybe they were better off that way, I don't know. That you have a dynamic where you have at least one side of the two potential groups that is looking at the number of services. So, you can have both. There are a lot of reasons why it's hard to get, especially in the senior population. People who want to have or feel it's appropriate for them to have a financial stake, but you would like to have then the clinicians or the setting that they're going to be mindful of what is going on.
I think one of the barriers to the chronic care management fees that went into place, or one of the concerns the agency had at the time, that the Medicare statute says that for every service there shall be a copayment, 20%. And a lot of the things that we care about and we want to see happen within the fee schedule development is that we incent care coordination. We incent services that aren't necessarily visible to the patient. And the staff at the agency at the time was really concerned about the fact that a beneficiary might get a bill for a service that he or she never saw. And how would they react? I don't know what the experience has been since the chronic care management fees have gone into place, and maybe physicians don't bother collecting the fees, even though they're supposed to, because of that patient pushback. But I think that's the kind of discussion that we should have, is what is the role of cost sharing within the fee schedule? Do we need to have every service have a cost sharing? Do we want to waive for some? But there is a dynamic that people expect to pay for a service out of their own pocket when they actually see that care being delivered directly by the physician. And it's I'm not sure we solved that issue, but it came up certainly during the time of the chronic care management fee development.
Hi, I was very intrigued by sort of the undercurrent.
Could you identify yourself, please?
I'm Dina Puskin, and for many years I was an employee of HHS. I'm now retired. So I was intrigued by the discussion first on innovation and whether in fact the fee schedule inhibits innovation. And I will say, at least in the area of telemedicine and telehealth that I've worked in for many years, it does, by and large. And the question really comes down to, and I think Bob got to it a little bit, you know, you don't want to pay for every email, and you don't want to pay for every phone call. But the question is, how do you take innovation and make the most of it for the Medicare population? And I've got to tell you, there's a lot of innovation in payment now going in some of the private payers. And my concern is, are we learning from that for the Medicare population to see how, in fact, we can incorporate the digital, as Eric talked about, the digital revolution that's occurring into, in fact, making practice more efficient and effective for this population. And that gets a little bit to also what Gail, who's left, talked about her concern that the fee schedule may be inhibiting that. And so if there are any thoughts you have right now about how we might take this next step and learn from what's happening in the private sector and take it into the Medicare population.
Well, maybe I'll jump in with a brief comment, just that the Commonwealth Fund has been studying this delivery system reform efforts around, and in particular, I think the Medicare Advantage. So we have case studies and we're making other attempts to try to share what are the lessons learned as companies like IORA, CareMore, ChenMed are actually taking risk under Medicare Advantage contracts and then developing these innovative care models. Whether that informs how we think about the physician fee schedule and valuation, I guess that's the loop back I was trying to make, and we don't have material on that, although I think that's something that would be interesting to develop.
Yeah, I think the other point is that the Center for Innovation that was authorized in the Affordable Care Act was really the purpose to take ideas outside of the traditional fee schedule process and test and develop. I think there's no limitation that I'm aware of that you couldn't test different telemedicine reimbursement policies. We don't have to have care redesign tied into, or different delivery designs tied into these payment models that we test. And so, if there is desire to test better ways to pay at the micro or at the individual service, like telemedicine, the Innovation Center has that authority, and I think some that developed it really wanted those models to come forward. And so I think you, as a right, as a citizen and a taxpayer, have the right to suggest those models to the Innovation Center, and would encourage you to do so.
Is Canada paying medicine for rural areas?
Yes,
Fee for service.
I just want to make one point, as we've talked today about the disparity of income between primary care and specialties and so on and so forth. And I think there's a tendency to think that when we talk about better payment for primary care, what that really means is more money in the doctor's pocket. And that's a mistake in a way, because the other aspect of this is paying for infrastructure that people need in order to meet the expectations of the evolving care system. And even things like being able to report quality measures is not simple, and you need people that you have to pay to do that. And I think that there's no question that in primary care, the fee schedule and the inadequacy of the payments to primary care has retarded innovation in primary care because of the inability to afford the infrastructure that you need to do the care. I mean, try practicing geriatrics. A doctor can't do that by himself, him or herself. You need staff, you need resources, and it's not only an issue of how much income people take home, but what kind of infrastructure, what kind of environment they're able to practice in. I guess that's not a question, that's a comment.
So just a comment to Eric about the impact of innovation. So having lived through the deployment of a very dysfunctional EHR and having shared this experience and learned from the experiences of my colleagues throughout the country, I am quite skeptical, honestly. It's going to take us a long time to figure out how to optimize technology in medical care, partially because institutions and enterprises have already sunk literally millions of dollars into systems that they are loath to walk away from. It's just kind of one of the scariest aspects of high tech. But I wanted to just go back to the kind of focus on value-based outcomes. So I was intrigued by Simon's comments about the UK experience, and 90% of the primary care docs are achieving the criteria. And then I thought about what you said, Karen, about how people have walked away from MIPS. Honestly, I was totally not surprised at all. I think that the modeling of MIPS is just terrifying, and I think that the effect to sort of herd people into enterprises was, I predicted this a year and a half ago. I knew it was going to happen because people look at those metrics and they look at how close the narrow is going to be at the top. So I think my guess, the fear, and just like people's thoughts about it, is that we've entered into just yet another sort of dark hole here. And so we're still trying to figure out how to make the fee service work. Now, a quarter of a century later, there's some pretty clear problems. And I worry that we're sort of shifting to this new, we've got a new love here. We got a new relationship with somebody that looks so attractive and so compelling. It's so nice to think about value-based payments, but it's inoperable. It's like teach to test. I mean, I think we all know what's happened with education is that there's been this real shift toward the curriculum designed specifically to pass high-stakes testing at the sacrifice of like arts and literature, because those things are not easily tested or not tested at all. And I think we as a profession, and especially as leaders in this sort of movement forward, need to kind of look around and say, what have we done here? Are we creating something that's going to plague us with a whole other set of problems? And I guess that takes me back to what I think is Bob's thesis, is that, maybe our energy would be better spent trying to make sure we did this one thing right, because if we don't get this one right, it's going to hang over our heads forever. And if we spend now our energy focusing on something new based on a very flawed system, could we end up in an even deeper hole than we're in right now?
If I could just weigh in on the technology piece, because I think it was actually said earlier, I think that EHRs were just glorified billing systems that had a documentation aspect to them. But we have also written an article on the IT productivity paradox in healthcare specifically. And the insight there is that it's not about digitizing the existing workflow. It's changing essentially the staffing and workflow based on the opportunities that the new technology presents. So you're absolutely right. It will take time for that to happen. That's not a slow or easy process. But if you look over the last 100 years, the introduction of any technology, there's this sort of 10 to 20-year period of experimentation as people try to figure it out. And that's the sense in which I worry that the PFS can get in the way if it's locking in existing workflow patterns, when what we really need to think about is how, through maybe CMMI or other demonstrations, how to actually redesign the way we deliver care based on the technological capabilities that exist to do that, whether it's moving care to the home or moving care in other settings.
The other thing that I would say is what I worry about a little bit, or that we should maybe acknowledge, is now that we've been in these systems now for many, many years, how sophisticated people get to understand how these systems work. So, for example, in the hospital, we did DRGs back in '83. There was a wage index. People didn't pay too much attention to that. They understood it. And now everybody understands exactly how much money moves through the hospital wage index. And to make any changes to that is very, very difficult because people know and are very sophisticated about how it works. MedPAC on the practice expense, I think, several years ago said, well, let's go out and we'll get volunteers and we'll try to do this thing. And it was very hard to do because people now understand exactly how important the practice expense is, how important the gypsy is. And so I think as you look and say, well, let's re-look at doing this, my only worry is that we're much more, it seems, that we're much more sophisticated. There's many more consultants who are around who can say, this minor thing actually makes a very big difference, so go in and fight that issue, where it seemed in the 80s, maybe I'm wrong, but there seemed to be a little bit more freedom because hospitals and physicians weren't exactly sure what was going on, that people could just put the system together. And I think now we're more in a fishbowl, so to be able to make some of these changes, I think it's going to be much more difficult, and much more difficult politically.
But I would say you're making an argument for why we need to get empirical data rather than relying on when Shao was doing his study, he had very good participation, and nobody knew what the game was. I think that, so it's difficult. Steve emphasized it's difficult to get the data, but I think it could be done. And again, I would just argue if you're spending $90 billion, don't you want to base it on something objective rather than some estimates from 30 or fewer people? It just doesn't make sense to me.
This might be a good time for me to bring this to an end. I want to thank the Commonwealth Fund for its support, and also mention how great it was to work with Eric and John Bishop from the Commonwealth Funds. I want to thank the three other collaborators, Bob, Katie Merrill, and Steve Zuckerman, who worked to plan this conference. And thank staff, Jason Fast from the Urban Institute, Marcy Gabello, and Abby Durak from Brookings. And finally, I want to thank this panel for very stimulating discussion.